Yes, we can
Okay.
begin because some people are telling me are using one device to 5 or even to 10 people. So
Okay.
that is hard to assess and know the number who is attending while they are using different one device to many people. So we can
Sure.
start what they are telling me.
Okay. Okay. Thank you everyone for joining us today. Before we get started, a few reminders. We will be using the chat function for question and answer. The button to access this is at the bottom of your screen. Please send all questions through the chat and feel free to introduce yourself. If you have any audio or sound or connection issues, send us a message through chat or WhatsApp, and we will be pleased to help you. And the session is being recorded, and your attendance is consent to being recorded. So thank you. So we are so pleased to be on session 8 today. The topic is high flow oxygen therapy and non-invasive positive pressure ventilation for adult patients. The date is February 2nd, 2022. And as usual, we have our wonderful panel of teachers, Dr. Francois Xavier, Liberata, Dr. Joseph, Dr. Venuste, and Dr. Apollinaire. And with that, I will hand it over to Dr. Francois to get us started. Dr. Francois, you're quiet again.
Thank you, Alana, for your nice introduction to this session. We are going to have a session 8, which is now the end of level 2 of our session. As our level 1 ended up with 4 sessions, now level 2 session from 8. We are going to talk about high flow oxygen therapy and non-invasive positive pressure ventilation for adults. Um, Usual, and as every one of you knows, we start by case-based discussion, as our sessions are practical sessions based on what we are living with, the experience. We have of 39 years old male who presented with 5 days of worsening shortness of breath and dry cough. He's breathing very hard, and when he gets up and looks around, so he had tried to stay in the bed and rest. He noticed that his fingers and toes are blue. So the sign of being blue is meaning like there is less oxygen. When his breathing is the worst. The vitals are below 8 and SpO2 at and 90% on facial mask with 15 liters per minute. So still not on the target. Previously, this saturation of oxygen has to have a target according to different condition. And despite this 15 liter per minute, the patient is still having 90%. So what next is what we are going to discuss when you fail to use the facial mask, what you will do next. So objective of this session is about to change the practice into the therapy. We have to understand the upper limit of low flow devices. So meaning that we have to know what is low flow devices and understand the upper limit to know when to start the high flow oxygen flow devices. Differentiate between low flow oxygen therapy and high flow oxygen therapy. This time in Rwanda or in COVID situations, we are using words like that. A patient is on high flow, a patient is in high flow. What do you mean by saying patient is on high flow? I hope at the end of this session, everyone will be clear to know how to differentiate patient on high flow and the patient on low flow. We will also understand when to escalate to high flow oxygen therapy, knowing the benefit and the complications of high flow oxygen therapy as any other medication, complication, benefit or advantages are always they have to be considered. Also understand how to up titrate titration of oxygen therapy, titrate up and titrate down, how many you need, how low you need, according to your target saturation. So we end up by also introducing non-invasive positive pressure ventilation, where you have to know indication of non-invasive pressure ventilation, and also, as I said, as any medication, benefit and the complication of our treatment plan in oxygen delivery. For next, for better understanding of our objectives, our companelists are going to go through. We start by Dr. Polinaire, and he helps us to understand what is high flow and what has limitation, and also when to start it or escalate in oxygen therapy. Thank you and welcome Dr. Polinaire to discuss with us the high flow oxygen therapy.
Thank you, Xavier, for your introduction. Can you hear me?
Yes, we hear you, Doctor.
Okay. As we started with this oxygen therapy course, we know that there are some devices we used to have, like nasal cannula, facial mask, non-rebreather mask, venturi. We are not used to that. But with the COVID, some people were requiring high flow oxygen. My presentation will be on the high flow oxygen, low flow oxygen, to know when do we need low flow oxygen, when do we need high flow oxygen, and then limitation to that. Can I have next slide? Next slide, Alana. Okay. A part of those low flow oxygen machine or devices have high flow oxygen. As you can see, it's a setup who has different devices we use to heat the oxygen, to humidify the oxygen, and to deliver to the patient. And those high flow oxygen have to deliver more than 15 liters because we are used to those. The highest we have is the mask with reservoir, where the highest flow we can give it's 15 liters per minute. But with those high flow nasal cannula, they can go above those 15 and can alive up to 60 liters per minute flow. Meaning that if you have failed with your patient on mask, as we know, we have been seeing in the previous presentation, our patient can benefit from nasal cannula. If there is a failure, we go to oxygen mask. If there's a failure, there is a mask with reservoir. If there is a failure, we can try high flow oxygen because as we have been seeing in our courses, intubation of COVID patient has increased the risk of mortality. Meaning that with this course, at the end of this course, everyone will be able, if there is a high flow nasal cannula oxygen at your settings, you will be able to explain to others and to provide it to our patient. Next slide. Next slide. Okay. As a definition of high flow oxygen, it's a breathing support which is continuous, and it is made that it can warm our oxygen up to 37 degrees and at the same time humidify it. Is used when we have failed with those low flow oxygen therapy, and high flow oxygen therapy, as you can see, it reduces the effort the body needs to. It is with the high flow, its pressure can go easily into the lungs with a small effort of the patient. Next slide. There is evidence that patients who benefit for those high flow oxygen, when they have ARDS, it can be controlled without intubating the patient, or this high flow oxygen may help us to delay the intubation of those patients, as long as we saw that intubation may not increase mortality to COVID patients. Next slide. Okay. Rationale of this high flow oxygen therapy, you know that most of the time air it's not humidified, or when it's humidified, it produces bubbles. And then with non-humidified oxygen, it dry our nostril and our airway. Also, insufficient heating, or it can lead to poor tolerance of oxygen to our body. And then you know that those low flow oxygen therapy, they have a consistent fraction of expired oxygen because they deliver less than 15. And then we know that they can alive up to a FiO2 of 60%. With that high flow oxygen, it may help us even to achieve more than 60% of our oxygen. Next slide. With an experienced high flow nasal cannula in hospitalized patient who had COVID, the study was done in China. They have shown that it reduces the failure of respiration, and as you can see, 17 of patients who have been on high flow nasal cannula have improved compared to patients who have been not on this nasal cannula. And then that was done between 1 to 2 hours of this high flow nasal cannula. And then compared to non-invasive ventilation, also it has shown a good improvement on those patients. Next slide. Okay. As a difference between high flow oxygen therapy and the low flow oxygen therapy, as you know, most of patients on low flow oxygen therapy may develop, they are comfortable on low flow oxygen therapy, but those devices, they have inability to deliver precise oxygen concentration. On high flow oxygen devices, the patient may feel like obstructed, they may feel uncomfortable. It's why we say that it's better to use in a short time when there is, yes, you have to use in a short time, not as long-term oxygen delivery. And these high flow oxygen devices, they are able to give a precise oxygen concentration to our patient as they need. And then as you saw, you can give up to 60 liters per minute, which this one need infrastructure where there is a continuous source of oxygen, because while using a cylinder, it may depend on the size. Even the big one with 60,000 liters, you see that if there is a delivering 600 mils per minute, it will be for 100 minutes, which means if you don't have a continuous source of oxygen, you will need the high flow oxygen device will not be an advantage for you unless you have enough supplies of oxygen cylinders. Next slide. Okay, the low flow oxygen device, it supplements oxygen with low flow oxygen, as we said, up to from 4 liters to 15 liters. As you see on the nasal cannula, simple mask up to 60 liters, non-rebreather mask up to 15 liters. And the high flow, as we said, it's up to 60 liters. Next slide. Okay, as we said, indication for escalation of high flow oxygen, there is high monitoring settings. That's indication for to move your patient from low flow to high flow oxygen therapy. Acute exacerbation of COPD, post-extubation, you can put a patient to high flow. Pre-intubation for oxygenation. For patient with sleep apnea, you can use high flow while they are sleeping. Patient with acute heart failure, patient who are not intubated, who have signed not DNI, don't intubate me. Patient who have a long bronchoscopy, you can use high flow nasal cannula while in bronchoscopy. Also, you can use it for long-term support respiration. When the patient cannot tolerate mask and he has a lung injury, the high flow can be used as long-term support. And then the patient is requiring more than 60% of oxygen. If you don't have ventilator, and the non-breather mask cannot provide that. And another indication, if the patient is requiring more than 45 oxygen, you know, that also will be a temporary measures while looking for improvement or escalation to intubation. Next slide. Okay, as you can see on the image, when should high flow nasal cannula be used in clinical settings? As we said, is when the patient has hypoxemic respiratory failure, following extubation, post-operative, in high patient or high risk or obese patient, following cardiac and thoracic surgery, or peri-intubation period for oxygenation. But most of time, this is not recommended as long as there is other maneuvers you can use for peri-intubation period. Next slide. Okay, our slide is showing when escalating for high flow nasal cannula, high flow oxygen therapy. They are like parameters. If the flow rate ranges from 5 to 60 liters per minute, as we said, when you want to increase and there is a respiratory failure on the previous method you have been using, and when your oxygenation failed adequately, or you want to improve the oxygenation, or when the breathing is a problem on low flow oxygen therapy. Another parameter to be considered when you escalate to high flow oxygen therapy, it's when the FiO2 you want to maximize up to 100% without intubating the patient. You can switch to conventional oxygen system once the flow rate reaches less than 20 liters per minute, and the FiO2 is less than 50%. At that time, you can switch to non-invasive ventilation or to escalate to invasive ventilation. Next slide. Okay, we intubate patient if we consider like there is a failure on high flow oxygen therapy, and then we consider to intubate when the patient is still tachypneic and the rate is 30 cycle per minute, and then or when there is a poor oxygenation, there is not improvement of POA2 too high, FiO2. PO2 also is 92, while you give the maximum of FiO2 you can have. When you have tachycardia, meaning that at that time also the cardiac is involved, or when there is hypotension, you see that this patient is decompensating and then soon be having respiratory and cardiac failure. At that time, immediately you consider intubation so that you can save your patient. The next slide will be for the video. We can have the video for high flow oxygen therapy. Alana, can you play it?
Therapy. High flow therapy is when oxygen is being delivered to the patient at a flow rate that meets or exceeds their inspiratory flow demand. What does that mean? Well, did you know that at rest, the average adult will inhale at a speed of 20 to 30 liters per minute? In other words, if someone was standing next to you right now with a radar gun pointing at your nose, capable of measuring how fast you're inhaling while you're relaxed, the speed at which you inhale would be at around 20 to 30 liters per minute. So high flow therapy should be capable of matching the inspiratory flow, or even exceeding it. If an oxygen device delivers less than the patient's inspiratory flow, then the delivery is called low flow. So because the average adult who is at rest inhales at a speed or flow of 20 to 30 liters per minute, a high flow device should be capable of delivering at least that much. Now, in order for this high flow of oxygen to be comfortable to the patient, the oxygen should be heated and humidified to maximize patient tolerance and comfort. And sometimes you'll see high flow therapy described as heated and humidified high flow oxygen therapy, or heated and humidified high flow nasal cannula, or to keep it short, it may be referred to as HHFNC or HFNC or even HFOT or HFT or some other variation of that. More recently, Vapotherm has chosen to refer to their heated high flow therapy as HVNI. They've even tried to describe HVNI as mask-free NIV, but don't get thrown off. On the FDA's website, it clearly identifies their device type as high-flow humidified oxygen delivery device. Now, like other high-flow devices, they deliver a high flow of oxygen and it is heated and humidified to help meet patient comfort and tolerance. And some devices, like Vapotherm's Precision Flow, go up to 40 liters per minute. Others, like the F&P Airvo 2, go up to 60 liters of flow, while still others can go even higher. Because at the end of the day, we're just trying to meet the inspiratory flow of a patient, and when that patient is in respiratory distress, that inspiratory demand can be as high as 100 liters per minute. Yikes. So should high flow therapy be a replacement to other forms of therapy like non-invasive ventilation? The answer? Absolutely not. High flow oxygen delivers just that, a high flow of oxygen. But sometimes patients have issues with CO2 or ventilation, and not just issues with O2 or oxygenation. NIV is effective for both oxygenation and ventilation. This is why HFT and NIV are often used together on some patients in a complementary fashion. For example, some patients may be on high flow therapy but require more support. Clinicians sometimes escalate to NIV to prevent, if possible, intubation and invasive mechanical ventilation. And if a patient is on NIV and can tolerate short breaks, clinicians sometimes switch to high flow therapy to allow the patient to have that temporary break from NIV where they can eat, talk with their relatives, take an oral medication. You get the idea. In fact, in a sponsored study, there were 104 patients who presented to the ER in respiratory distress, and they were initially placed on high flow oxygen. Of those 104 patients, unfortunately, 27 of them failed, and of the 27, 4 were immediately intubated. But the other 23 patients were switched from the high flow oxygen to NIV. And of the 23 patients who failed with high flow oxygen and were switched to NIV, 20 of them improved and did not need further escalation to intubation. In fact, in another study, patients at high risk of post-extubation failure were placed in one of two categories. The first category was high flow therapy only, and the other group allowed for both NIV and high flow therapy. Now, the patients that went on both NIV and HFT had a significantly lower rate of reintubation versus the group that went on HFT only. So don't get confused. HFT is definitely not mask-free NIV, but it is a great tool to treat patients with oxygenation issues who are in respiratory distress. So just a quick final summary on high flow therapy. High flow oxygen therapy usually delivers oxygen at a flow rate equal to or higher than the patient's actual inspiratory flow rate. It should be heated and humidified for patient tolerance, and depending on the flow rate and the seal around the nose and mouth, high flow oxygen may create a Cpap effect, although we don't know exactly how much. It also may wash out some CO2 that is in the upper airway, which is often referred to as CO2 dead space washout, but again, we don't know exactly how much. So that's your quick introduction to high flow therapy.
Okay, thank you,
Thank you,
Alana,
Dr.
for.
Thank
I
you.
would-
Yes, Paul.
Okay, this video is summarizing all what I have been saying as a conclusion to this high flow to low flow oxygen therapy. Everyone who are attending this session, it's like as a take-home message, a recognition that our patient is needing escalation to high flow, and then early supportive care and escalate. As you saw on the video, there is when you use high flow oxygen therapy, you end up having a good result than intubating immediately the patient. Thank you. That's the end of my presentation. Any question through the chat, I will be responding. Yeah.
Yeah. Thank you, Dr. Ponel, for the presentation. The message here, as you said, people has to understand really what is high flow oxygen therapy, and we have been had that we have a patient on high flow, we have a patient on high flow, but from this video and from this presentation, our audience here now clear that the high flow oxygen is when you are delivering an oxygen which is higher than the normal inspiratory flow of the patient. So mean that the time you are giving the flow less than that inspiratory flow of the patient is what is low flow. And we know that the inspiratory flow of the patient is in between 20 and 30 liters per minute. So when you are above that, the time we start to say high flow oxygen therapy using the mean of high flow devices, not using the mean of low flow devices to high flow devices. The other thing for the people who are having the high flow oxygen therapy device, like people are here in some center of COVID, like Cannula or Nyarugenge. On that device, there are two types of parameters you have to set. There is the flow rate you have to set, and also there is FiO2 you set. As in the video, they showed you that the FiO2 you are able to set from 21 to 100%, and the flow rate is from 20 to 35 liters per minute. So that is the time your FiO2 according to the need to meet your target in terms of oxygenation. And when you meet your target, you can also de-escalate down to other low flow when your need is less than 50% of FiO2, or you are less than 20 liters% of your high flow nasal cannula. So that means every people is clear about high flow versus low flow oxygen therapy in our settings where we are. That is a message. So be clear about the communication in terms of oxygen therapy. Our case then, despite whatever has been done, our case on oxygen mask reservoir has a fast rate, tachypnea, and his respiratory rate was now 36%. SpO2 was still falling 88. The bedside provider decided to place him on high flow oxygen therapy. So next presenter is going to help us to understand the benefits and also the complication and how do we deliver oxygen therapy. Next, please, next presenter here is Dr. Venice to help us to understand. Thank you.
Thank you very much, Dr. Xavier and the team for the nice presentation. So the next topic is, or part of this presentation is about the physiological benefits of high flow nasal cannula. Can you please go to the next slide? The next one, I think it explains much better the physiological benefits of high flow nasal cannula. The next slide, please. Alana, can you please go to the next slide? It much better gives the benefits according to the mechanism by which those benefits, yes, this one. Yeah, so the high flow nasal cannula, it uses the nasal prongs which are pliable and they are small, and this gives patients comfortability because they are not more rigid. And as you have seen in the previously played video, the gas or the oxygen delivered in the high flow nasal cannula, it is heated to an average of 37 temperature, and this warm oxygen will make the patient more comfortable, and it will not cause bronchoconstriction. Oxygen is not warmed enough, it can give bronchoconstriction, impairing the ventilation and later the oxygenation. So this oxygen also being humidified, it will allow the mucociliary function to be conserved, and there will be no airway dryness, and the epithelium is not destroyed, and this will decrease the work of breathing. So also the high flow nasal cannula, the other advantage is that it gives a washout of nasopharyngeal dead space. So with the increase in the flow rate, you increase the pressure in this conducting airway space from the nose to the bronchi, and this pressure will try to open the alveoli, which has collapsed, and you improve the oxygenation and the ventilation at the same time. So also this mode of oxygen delivery, the high flow nasal cannula, it gives an increase in the positive end expiratory pressure, and this will reduce the work of breathing for the patient, and it will eventually enhance the oxygenation for the patient. So with the high flow rate, of course, you will deliver a constant fraction of inspired oxygen, and this will improve the breathing pattern, like by increasing the tidal volume, but also decreasing the respiratory rate. So these are the 5 main mechanisms by which we can observe the physiological benefits of high flow nasal cannula for a patient who are hypoxic. Next slide, please. So this slide is for complications of high flow nasal cannula. We have a chest X-ray for a patient who had high flow nasal cannula, and this has caused subcutaneous emphysema, and we can see in the increased air bronchograms, likely from pneumothorax in the right apex. So as the complications this high flow rate, which can give an abdominal distension, it can as well lead to aspiration, but also it can cause barotrauma or pneumothorax. So this barotrauma, however, it's less likely in high flow nasal cannula if you compare to non-invasive ventilation or mechanical ventilation when the endotracheal tube is in place. Next slide, please. So as you have seen in the setup of high flow nasal cannula, so the contraindications are mainly due to anatomical limitations, if I can say, like in a patient who has abnormalities or surgery or trauma to the face or nose or upper airways, you can't see appropriately fit the nasal cannula for those types of patients. So you can directly go to the intubation or use a tracheostomy if these are the barriers for high flow nasal cannula. So some experts may avoid high flow nasal cannula in those patients following upper airway surgery to avoid a theoretical risk that the high pressure may precipitate a venous thromboembolism. So this has been observed in patients who have trauma or surgery in nose or upper airways. Next slide, please. So regarding the initial settings or adjustments or titration to improve the oxygenation in a patient who is on high flow oxygen therapy, we have seen that the previous video that the flow rate and the expired FiO2 are the main ones you titrate to try to optimize or reach your targets for the patients whom you are giving oxygen with high flow nasal cannula. Next slide, please. So regarding the flow, the targeted physiologic variables show the most benefits at higher flow rates. And you have to consider the patient's comfortability and the compliance as the factors that will guide you to know the flow rate you have to set. And the set flow should take into consideration also with the severity of the patient's condition. Like in a patient with mild ARDS, they won't require the same flow rate as patient with severe, like moderate ARDS. And in all patients whom we are going to start high flow rate, high flow nasal cannula or high flow oxygen therapy. So the minimum flow rate should be 30 liters per minute. And the more the patient is dyspneic or the patient has tachypnea, they will require more flow rate and up to 60 liters per minute. And if there is no improvement on the flow rate you have set it, you can consider increasing to see if your oxygenation targets and patient's comfortability and respiratory rate are improved. So when the patient, this patient and comfortability, it may be due to the velocity of the oxygen itself rather than the flow rate you are using. And this can be eased by using a large bore nasal cannula. Next slide, please. So you can also, so you want also to warm the oxygen in this mode of oxygen therapy and temperature to 37 Celsius. But also you have to, for the oxygen, you titrate the inspired FiO2 between 21% to 100, and with a target to get between 92 to 96 in the general population, as we have seen in the previous sessions. For patients who have like chronic respiratory disease like COPDs, go for oxygen therapy 8 to 92%. Your target to consider intubating the other concentrations, okay, patient relative preferences. Next slide, please. So this is a device which used to calculate IO2 and flow.
Dr. Finiste, your sound is cutting out. A little hard to hear. Your sound is cutting in and out. Maybe if you could try to plug out your headphones or plug them back in.
Hello, we can't hear our colleague. We can't hear our colleague. Can you hear me?
Hello.
Hello?
Hello.
Yeah, come back.
Yes,
Come
we can
back.
hear you, Dr. Savio.
Hello. Do you hear me?
Our colleague Venice, but here is a picture of a high flow oxygen therapy device with different. I see some places where to adjust the flow meter. There are some flow meter. We are having also where we can adjust the FiO2. This is the device, and I think it's available in Rwanda. People can access on it and use it according to what we had from in this presentation, such in the indication of using high flow oxygen therapy, consider complications, and also what parameters you have to set. As Venice was explaining, you set FiO2 in oxygen you need, the flow meter according to the patient's condition, and also the temperature. Is here where we lost our colleague, and if he is back, he can also intervene. But if not, let us keep going to the next slide, please. So the next slide, we are going now to watch this video. It will be more explanation about what we are talking in terms of settings and also physiological benefits and application in our clinical settings where we are working. Let's watch it
Video,
in a
we
few
talked a
minutes
little
and then go to the other part of the video.
bit about what high flow therapy is. In this video, we'll quickly highlight the clinical application of high flow oxygen therapy. We already discussed that high flow therapy is not a replacement for non-invasive ventilation because it is not capable of providing the same level of ventilatory support like NIV. In high flow therapy, for example, there is no inspiratory pressure setting, no PEEP or Cpap setting, no backup respiratory rate setting, no inspiratory time setting, no patient ventilatory alarms. You also cannot monitor the tidal volume, the IE ratio, and there are no loops or waveforms. You get the idea. NIV, on the other hand, can provide all of these. In fact, the only two main controls on high flow therapy are FiO2 and flow. Let's look at FiO2 first. This is typically adjusted to maintain adequate oxygenation. The FiO2 can be set from a level of 21% to a level of 100%. Usually, patients in acute respiratory distress who are on high flow may initially require a high level of FiO2 to maintain an appropriate saturation. Next is the flow setting. The flow is usually set to try to meet or exceed the patient's inspiratory flow demand. This is challenging because it's difficult to determine what the patient's inspiratory flow is. We learned in the previous video that at rest, when the patient isn't in respiratory distress, the typical inspiratory flow of an adult is around 20 to 30 liters per minute. But for patients in distress, their flow demand will likely be higher. So clinicians often titrate the flow according to the patient's respiratory rate. In other words, the faster the patient is breathing, the more flow they'll probably need. So if you're using the Vapotherm's precision flow device, the highest flow that you can set is 40 liters per minute. On other devices, like the Airvo 2, they can go as high as 60 liters per minute, and still others can go higher. So these two settings, the flow and FiO2, are the two settings available to the clinician to treat the patient in respiratory distress. If the respiratory rate or the CO2 on the arterial blood gas cannot be corrected or stabilized despite a relatively high flow rate setting, you may need to escalate to non-invasive ventilation or even intubation, depending on the severity of the hypercapnia. Likewise, if the pulse ox or the PaO2 on the arterial blood gas cannot be corrected and stabilized despite a relatively high FiO2 setting, then be prepared to escalate to non-invasive ventilation or even intubation, depending on the severity of the respiratory failure and the diagnosis of the patient. But whatever you do, do not delay escalation if the patient does not improve with high-flow oxygen. Okay, now remember, because there are no patient alarms and data monitoring is not available on high-flow oxygen devices, regular patient monitoring is critical. There is one more control in high-flow therapy, and that's the temperature setting. To ensure that the high flow of oxygen is tolerable, heat and humidification should be provided. The exact appropriate temperature setting is debatable, and there currently exists no temperature standard. Some suggest to start at 37 degrees Celsius, others suggest start lower. But the key point in temperature setting is to adjust the temperature based on patient comfort and tolerance. Which patients should high flow therapy be placed on? It's still a bit unclear, but we tend to see good outcomes in patients with what we call de novo hypoxemic respiratory failure. De novo hypoxemic respiratory failure is defined as significant hypoxemia but in the absence of chronic lung disease such as COPD. We also do not include the kind of respiratory failure that occurs in the immediate postoperative or post-extubation period. Remember, high flow therapy can deliver a high FiO2 at a high flow rate, so we anticipate it to be beneficial for hypoxemic patients. However, if a patient presents with acute hypercapnic respiratory failure, which is exhibited by an abnormally high CO2 and a corresponding abnormally low pH, then clinicians may want to consider an alternative form of intervention, such as NIV. Well, what about you? How have you seen high flow therapy used? Leave your comments below. I would love to read some of your responses.
Yeah, I hope with this video, everyone now is clear on the clinical application of high flow oxygen therapy, indication we had on how to set it. And I think you are going now, if you fail, as all presenters emphasize on, if you fail this high flow oxygen therapy, please go to non-invasive positive pressure ventilation before you step up to the intubation, which is invasive. So let me call in Madame Liberata to present to us what is non-invasive positive pressure, indications and complication, even though some benefits, and we end up with this third part of our day's presentation. Liberata, welcome, please. Liberata, the ball is in.
Thank you so much, Dr.
Yeah, keep
Yes.
going.
Thank you. Thank you. Can you hear me well?
Yes, we hear you.
Thank you so much. This is like a step forward from what my colleagues have been presenting, and it's what we decide to do when we are trying everything with high flow nasal cannula, but the patient is not improving. Can you go to the next slide? Next slide, please. Thank you so much. There is updates on the case that we started with. Here is with our Mr. G, who is remaining on high flow oxygen therapy with the following settings. The temperature was at 7 degrees, FiO2 was 100%, the flow was 60 liters per minute. After 2 days of initial improvement, his SpO2 is 90%, but he's more tachypneic with respiratory rate of 35 breaths per minute. He appears fatigued and his arterial blood gas analysis reveals the following. Let's look with much attention on this blood gas of expressions. The pH was 7.27. The PaCO2 was 58 millimeter of mercury, and the PaO2 was 60 millimeter of mercury. So now the bedside team decided to try the non-positive pressure. Arana? Hello?
Yes.
Hello, Alana? There are some voices behind.
I keep going.
Okay, I was saying to look with much attention on this ABG for us to understand why do we need to use a non-invasive positive pressure ventilation before moving to the intubation if our patient fails again. Can you go back to the previous slide, please? Just a second, go to previous from the participant. Go back to the previous slide, please. Can you hear me?
You are clear, Berata. You can continue. You can hear you.
I wish to go back to the case. Yes, thank you. I wish to hear from participants if they look at this ABG, this blood gas. What do you find? What is abnormal from this ABG? If no idea, you are also allowed to say that you don't have any idea. Please chat. Please chat.
You can also
Brigitte,
call some names you see. You
use
can
the
call
chat
some
and
names.
tell us. Yes, I'm calling Brigitte. Tripine, greetings. Yes, there is respiratory acidosis. Thank you to Ishime. So much. It means there is a low pH which is below 7.5, and the PCO2 you see that it has increased to 58 millimeter of mercury, and PaO2 is 60 millimeter of periphery we have here. Marte, what types of respiratory failure do we have here? Anyone else? Dr. Chuahiro, what type of respiratory failure do we have here? No response. Let's quickly intervene. As you see, the PaCO2 is increased and the PaO2 is decreased, which means we have an issue of ventilation because the CO2 is not. Tachypnea is a sign. Thank you, Tripin, for trying. Tachypnea is a sign, not type of respiratory failure. Thank you for trying. So PaCO2 is 58. It means the CO2 is not washing out. The patient is not cleaning away the CO2. It is accumulating in the blood. Then the PaO2 is low. This is why the patient is tachypneic is trying to do compensation. So it means the patient is having a mixed respiratory failure where the patient is having hypercapnia and hypoxia. So now the bedside team decides to try NIPPV because with non-invasive positive pressure ventilation, we are sure that if we talk of non-invasive positive pressure ventilation, we understand we have two options. One is the Cpap and the other one is the BiPAP. The BiPAP has two like settings. We set two pressures, inspiratory and expiratory pressure, where we will be able to wash out this PaCO2 that other means like high flow oxygen therapy cannot do. But with NIPPV, with BiPAP, biphasic, positive airway pressure, this can help to wash out this PaCO2 and bring it back to the normal range with bringing back again the pH in the normal range. Go to the next slide. Next slide. The slide is not moving for me.
Can you see the slide with the picture?
The slide is not moving to me.
Yeah, they want to give some explanation or some clarification on this picture because they will help us and the people to understand what is non-invasive positive pressure, the way the mask is on instilled on the patients, and from this ventilator machine, and then we go.
I'm not on the picture.
Yeah.
Dr. Xavier.
Yes.
Dr. Xavier.
Yes, I hear
My
you.
slides are not moving. Thank you
They
so
are
much. I'm now
yeah,
on the slide
yes.
of the picture. Thank you. I'm fine. Okay. So positive pressure ventilation looks like they are telling that you see it's a very tight mask that is given to the patients just and it helps with the ventilator. It will help to set those pressures we are saying. Either we are using Cpap or we are using BiPAP, where two pressures will be set. So the statement here says that high flow oxygen is not a replacement for NIBPV or mechanical ventilation. You know that where the high flow oxygen has failed, the next step for NIPPV or mechanical ventilation can work. So as we have seen, high flow oxygen doesn't help with ventilation. If we talk of ventilation, understand removal of CO2 in the blood when it is high. So if we are using high flow oxygen, as the previous case study was showing, and the oxygen keeps accumulating, it means we need a non-invasive or positive pressure ventilation to help in removal of this CO2 which is accumulated. Next. Next slide. It's not moving. Alana, slides are not moving.
maybe you have our side in our
It's not moving to me.
I think it might be a connection
That's not-
issue, Liberata.
yes.
You might not be seeing it
Mhm.
move on your side because of the slow internet.
Let me try and see.
So
It's not
why
coming.
it's coming?
It's not coming.
Yeah, sorry for network problem to our colleague Liberata. Let me back her
It's
so
okay,
that we can
Xavier.
continue. Yeah, you are okay now?
Xavier, I'm going to use the same slides so you will make sure that I'm on the same slides as you are. So the next
you.
is on the definition of non-invasive positive pressure ventilation. So it is defined as a ventilatory assistance without an invasive artificial airway. And it means we are not going to insert any tube in the airways of our patient. We are just going to use a mask. It is delivered to a spontaneously breathing patient. It means a patient will be spontaneously breathing, but we are just adding pressure for him or her to, it's just a support via a tight fitting mask that covers the nose. Either the mask can cover the nose or it can cover both nose and the mouth, or sometimes it can cover the whole face. So as a tension that we have to make, we should make sure that the airways of these patients, the patients should be able to control to protect the airways, because with this non-invasive positive pressure ventilation, the airways are not protected. It's not the same as intubation, where we are sure that airways are protected. For this NIPPV, we should make sure that the patient is able to control the airways. It's quite similar to the previous case study that we have talked about. But the issue only is just to give a pressure for the patients to be able to breathe in and breathe out. The next slide shows different circuit setup for this NIPPV, where we have a mask which can cover a nose only. The other mask can cover the nose and the mouth, and the other masks can cover the whole face. So these are the different types of circuit that you can find in different health settings. So what is the indication? To whom will we decide to give this non-invasive positive pressure ventilation? Those people who are having acute exacerbation of COPD, remember, they are CO2 retainers. They tend to accumulate the CO2 in their bloods. When the CO2 goes up over 45 millimeter of mercury and the pH is below, when it is below 730, remember it's going into acidic side. So we need to support these patients with NIPPV, especially the BiPAP. The BiPAP, remember, it will help with ventilation, and the Cpap will help with oxygenation. Those are two options for non-invasive positive pressure ventilation, the Cpap and BiPAP. So someone with cardiogenic pulmonary edema or hypoxemic respiratory failure, we have seen these. Patients with don't intubate advanced directives. Some patients, when they are still fine, when they are not critically sick, they decide on their end of life. They say, some may decide to say that, please don't intubate me if I get critically sick. So we can support this kind of patients with NIPPV instead of stepping to intubation when they have decided for DNR, for don't intubate. I reach to the side of contraindication. If we have a patient who has cardiac or respiratory arrest, obviously this patient will not be able to control airways. Remember, this is used when the patient is spontaneously breathing, but when the patient has cardiac or respiratory arrest, we can't try this NIPPV. When the patient is hemodynamically unstable, we can't try it because the patient may deteriorate easily and the mode of ventilation is not helping. So if a patient is having severe upper GI bleeding, remember the airways are not protected. If we use this NIPPV, there is high risk of aspiration for these patients. If a patient is having facial trauma, remember the face mask that we're using is very tight, so we can't use an IPPV for a patient who is having a facial trauma. Upper airway obstructions, we can't use it because it's just external. It doesn't reach within the airways. If we put it there and yet the airways are obstructed, we are not doing anything. When the patient is unable to clear secretions, it means the patient is not full or conscious. We can't use this one because these patients can be, the airways can be obstructed by these secretions. When the patient is vomiting also, we can't use it because airways are not protected. If you have any question, you will be using chat for me to know. So Cpap and NIPPV, remember it's the Cpap, it's one option within NIPPV. So we will not have much difference on that. What we can compare is the Cpap and the BiPAP to know when to decide to use BiPAP and when to decide to use Cpap. The next slide is about the benefits. What are the benefits of using Cpap, NIPPV? Then we compare them with the complications. So the first benefits is to decrease the work of breathing for our patients. You remember the case study for this session was showing how the patient was tachypneic, but with the use of NIPPV, the work of breathing will be decreased. The patient will not be struggling for breathing because he or she is having pressures which are helping. So there will be increases of functional residual capacity for helping alveoli to keep opened. And there will, of course, if alveoli are well opened, there will be improved gaseous exchange. And of course, it will help us to avoid intubation complications and costs. You remember when a patient is intubated, from previous sessions, we have learned many complications related to intubation, including the ventilator-associated pneumonia, the injury which might happen when someone is intubating, also a cost. When someone is intubated, obviously the cost increases. So of course, there will be decreases of mortality when the patients are properly selected. From my colleague, he was saying that early management, early detection can save our patients. So mortality rate will be decreased if we can analyze well the blood gas and know if the patients can be switched to non-invasive positive pressure ventilation. And again, we will be able to choose among the Cpap or BiPAP, depends on how the gas is. So as complications, of course, with pressure, there can be like barotrauma or simple pneumothorax. subcutaneous emphysema, facial pressure ulcers. You remember the mask, the face mask is very tight, eye irritation or tension of secretions, or gastric distension. Attention again, when we are using, you remember from the video, they were telling us that we need to do close monitoring of our patients. If an IPPV is being used, we have to monitor the patient within 1 to 2 hours. If there is no improvement, especially we are analyzing the blood gas. If there is no improvement, so endotracheal intubation should be decided and be done. So blood gas, of course, will be guiding us to know what to do. So the next slide to me is about the video, which will be explaining much on NIPPV, on how those pressures are set. If the time allows, we can watch it, or if there is no time, we can respond to questions if they are there. Dr. Xavier, the floor is back to you.
Yeah, thank you for the video, and we will have some comment after on it. The audience, pay attention.
Hello, my name is Nick, and in this video we're going to look at Cpap, continuous positive airway pressure, and non-invasive ventilation, also known as BiPAP, biphasic positive airway pressure. Cpap is a way of keeping the pressure positive in a spontaneously breathing patient's lungs. This positive pressure helps keep the smaller airways and alveoli open, which allows for additional gas exchange to take place by recruiting areas of a lung that might otherwise have collapsed down. A tight mask is applied to the patient's face to create a seal. Air and oxygen now flow through a circuit attached to the mask at high flow. The patient exhales through a valve which closes when the desired pressure is achieved. This pressure created by the valve is known as PEEP, positive end expiratory pressure. It's this that leaves the pressure in the patient's lungs at the end of expiration. There are several tight-fitting masks that can be used: oral masks, naso masks, full face masks, and Cpap hoods. Cpap has been shown to be particularly useful in acute cardiogenic pulmonary edema and congestive heart failure, where, in simple terms, the positive pressure created helps push the fluid out of the lungs and into the circulation and prevents further fluid coming back into the lungs. It could also be used for pneumonia, sleep apnea, and atelectasis. So what is non-invasive ventilation? Sometimes just keeping the alveoli open isn't enough, especially if the patient develops type 2 respiratory failure and starts to retain carbon dioxide. Think of non-invasive ventilation as Cpap with added zing. Non-invasive ventilation is used to increase the size of each breath taken by the patient. It gives an assisted push behind the breath which increases its size and thus reduces carbon dioxide levels by blowing off CO2. It seems to be most useful in conditions such as exacerbation of COPD and post-extubation on ITU. Some success has been reported with asthma patients as well as certain other respiratory conditions where there may be reluctance to sedate, intubate and ventilate a patient due to existing risk factors. So how does non-invasive ventilation work? As with Cpap, a tight-fitting mask is fitted to the patient's face, but this time the patient breathes through a mechanical ventilator. On the ventilator, two pressures are set. Firstly, the positive end expiratory pressure, PEEP, similar to that used in Cpap. As before, this pressure helps preventing the alveoli from collapsing. Secondly, the pressure that creates the push. This is the inspiratory pressure, which increases the size of each breath or tidal volume. The bigger the pressure, the bigger the push, the bigger the tidal volume. So let's assume that we set the PEEP at 10 centimetres of water. The pressure in the patient's lungs will not drop below this level. It's now the baseline pressure, if you like. Now assume we set the inspiratory pressure at 15 centimetres of water. Note that the inspiratory pressure is added on top of the PEEP. As the patient takes the breath, it causes the ventilator to initiate. It now increases the pressure until the inspiratory pressure is achieved. Once the inspiratory pressure has been reached, the expiratory valve opens, the pressure begins to fall, and the patient exhales passively until the pressure drops back to the PEEP level, where the valve closes to maintain the pressure. The inspiratory pressure can be adjusted until the desired tidal volume has been achieved, usually about 6 to 8 mils per kilogram. In addition to the pressures in both non-invasive ventilation and Cpap, oxygen levels must be set. For various reasons, this is frequently referred to as the FiO2, or fraction of inspired oxygen. The FiO2 is expressed as a fraction, so that 100% oxygen is expressed as an FiO2 of 1 and 21% oxygen is expressed as an FiO2 of 0.21. So, to summarise, Cpap uses high flow and positive pressure at the end of expiration to keep the alveoli open and improves oxygenation. Non-invasive ventilation gives a push behind each breath to increase the size of the tidal volume, which in turn lowers carbon dioxide levels. So that's it, a very basic overview of Cpap and non-invasive ventilation in under 5 minutes.
Yeah, I think we are almost at the end of our presentation, our session today. Everyone, let me say from the beginning, from our session 1 to our session 2, we are talking about oxygen delivery. In the first part, we talked about oxygen delivery devices, and we are still talking about them. This second part, it was just about the critical care in general, where we talked about air. Now we are talking therapy, and we talked about how we can organize our ICU and what is the rapid response team. So our part 2 is going to end today, and certificate for whoever attended 3 out of 4 sessions will get certificate with CPDs. Today, then let us take conclusion. Our take home today is everyone in therapy, coming from nasal cannula, facial mask, and non-rebreather, when it uses high flow oxygen therapy, when and what is it, non-invasive positive pressure ventilation. All these procedures of oxygenation to the patients are there to the patient in respiratory failure. Please go via every step. When you fail, go to the other one, but don't rush to the most invasive one with ET tube and the trachea tube of intubation. So we learned many methods of oxygenation, and I hope with this high flow oxygen therapy, you understand the limits of the low flow we are using. You understand how when you can escalate, you understand when and how you titrate from high to low, which indication, and when to switch to non-invasive positive pressure ventilation, indication and the benefit of it. We ended up with the video where they show us the Cpap and what you set in non-invasive positive pressure ventilation. At this time, you are starting using ventilator before you go step to the endotracheal intubation. So this is the message for today. And I hope everyone here has some clear information. We are going to start our part 3 about special consideration, where we have consideration in pediatrics, the next session, consideration in gyne obstetrics, and other consideration in emergency and essential and emergency care. So, and we end up by other questions, frequently asked the questions at the end of our 12th session. And I am inviting everyone to attend every session. It is benefit to us as providers, but also it's benefit to our patients when we are providing care, which we are confident of what we are doing. And there are not many announcements today, just that of whoever attended 3 out of 4 sessions will have certificate CPD, corresponding CPD. And from the next, sorry for my voice today. from our partners, please let me give floor to you. Our next session will be at 16th, and we'll be discussing about session 9 on pediatric consideration for oxygen and critical care. And I hope you to be here and invite other colleagues to be with us in that pediatric session. So I end up by thanking you, and I apologize for some interruptions. Voices are not well, and some interruption from the network. So to the next for our partners, India, Canada, or Assistant International, the floor is up to you. If there is any announcement, please welcome.
Thank you, Dr. Francois. Thank you, everybody, for joining today. If you would like to stay connected between sessions, if you have questions, we encourage you to join our community WhatsApp group. You can message the number on the screen or scan the QR code on the screen with your phone to join. The Learning Resource Center is a great place to visit if you would like to review the materials. I will share the link for that in a moment. And then, as Dr. Francois said, we'll be working on sending out certificates for CBT over the next 1 or 2 weeks. So keep an eye out for those emails as well. Finally, please save the date. February 16th is our next session on pediatric considerations for oxygen and critical care. And so with that, I'll let everyone go. Thank you so much again, Dr. Francois and all of your panelists for such excellent teaching today. Thank you to all of our participants for joining, and thank you to Echo India for supporting the webinar and Project Echo for funding this program. We hope to see you in 2 weeks' time.